Hi, it's Terry Kuti of Deep Sea Foundation. We're here to have a conversation to help patients through your consultation and care through their decision process for treatment, surgery, and survivorship. If you are a surgeon or healthcare professional listening to this interview, please take notes if you need to stop and listen. These are surgeons who have built a footprint for you with their successful practice. They care for patients with breast cancer. I would like to acknowledge the ARSA, that's the Advanced Reconstructive Surgery Alliance, and their leadership for allowing this time and space for me to do these interviews for you, the listener. This is a new setting for me, so it's kind of an exciting time to be interviewing some new surgeons today. Please share them with those who you feel may benefit from the information, and I'll have the contact information to reach out to ARSA to find a surgeon who may be able to help you at the end of the video in the credits, so be sure to look for that. So with that, let me introduce my guest. I'm speaking today to Dr. Tushar Patel. Did I pronounce that correctly?
Correct.
Oh, good.
Very nice job.
Excellent. He's a specialist in reconstruction after cancer surgery, traumatic injury, and the abdominal wall. He performs breast reconstruction and is double board certified in plastic surgery and general surgery by the American Board of Plastic Surgery and the American Board of Surgery. He is a fellow of the American College of Surgeons. So if you see the initials FACS behind a surgeon's name, that's what it stands for.
Correct.
Yeah. So his distinguished accomplishments, together with his interest in advanced reconstruction of the abdominal wall, have allowed Dr. Patel to be an active member of the reconstructive team at the Cancer Institute of New Jersey in New Brunswick. Because of his work in breast reconstruction and abdominal wall reconstruction, we are going to learn about a procedure that I'm privileged to know and learn about as we go through the interview today here at the ARSA Summit. Dr. Patel is part of the Institute for Advanced Reconstruction, which is part of the ARSA network of surgeons. He practices in Shrewsbury, East Brunswick, and Edison, New Jersey, correct?
Correct.
Okay. All right. Well, I want to get started on this absolutely fascinating topic that I don't know a lot about, and it's called bars. So I'm going to let you tell us what it stands for and what bars is.
All right. Well, thank you, Terry, for having me, and this is and the warm welcome.
Yeah.
So, bars sounds great. It's a great catch name. We spent a long time trying to come up with an acronym that would fit the operation. So, in simplistic form, bars, BARS, it just means Bony Anchoring Reinforcement System.
Mm-hmm.
And it's a generic term that we use to fix complex abdominal wall issues.
Mm-hmm.
Complex abdominal wall issues can come in a range of different variabilities. It could be from, like you had mentioned before, from sequela from having breast reconstruction, where we use the donor side of the abdomen as our tissue base.
Right.
It can be from traumatic injuries.
Mm-hmm.
It can be from just hernias, complex hernias from previous surgeries.
Mm-hmm.
So we use the bars techniques to tackle all these issues.
Mm-hmm. Okay. Well, that's what I have, specific interest in because in the community that I serve, Dr. Patel, there are women who have abdominal hernias. They have abdominal wall issues after they have procedures like deep flap.
Sure.
So I'm going to ask you a question that I tell other patients to ask their surgeons when they're looking for a particular surgeon. What is your success rate?
So that's a great question. And success rates vary depending on the underlying cause. The success rate may be different for a third, fourth time complex hernia repair versus a first time hernia repair.
Okay.
So on average, if we take all our numbers and we studied this and we've written multiple papers with our findings, our success rate is upwards of 95%.
That's a good number that we like to hear.
Good.
Yeah. So, can you go over the procedure a little bit, and then I want to kind of talk about what recovery would look like for bars? Because to me, when you tell me about it, it feels like a big surgery.
Yeah. So, if it can be a big surgery depending on the underlying cause. So the actual technique is just reinforcement of the abdominal wall.
Okay.
We have realized that people get laxity in the abdominal wall, whether they've had DIP flaps and the fascia has been violated, or the old school, tram flaps. We used to do a lot of those before. We don't do those as much anymore.
Right.
The vector forces of the abdomen go superior to inferior, so from top to bottom and out.
So let's stop just a minute, because you used a term I don't even know about. Vector forces.
Yeah.
Tell us about that.
So vector is just a direction of pull or push. Like it's a general physics term, and our vector forces in our abdominal wall are directed downwards and outwards. And it makes sense because when we sit and we stand, gravity pulls everything down.
Right.
And whenever we eat too much and we take a sigh, what happens? What pops out? It's not the top of your abdomen, it's always the bottom of your abdomen, right? So that's why it's the most lax area. And that's where typically these laxities in the abdominal wall or hernias, which are just holes in the abdominal wall fascia, occur.
Talk to me about, you keep talking about the fascial. And I know that's a term that I hear a lot when I go to conferences, but for patients to understand the importance of that fascial tissue that you're talking about, tell us what it's for, kind of where it's located, because I know there's different layers.
Yes.
Yeah.
So fascia, the layman's term, and I think most women will recognize this, think of it as an internal corset. So, or Spanx, right? So when you wear Spanx or an internal corset, you're just tightening the exterior so nothing pops out. The fascia is the same for the abdomen. It's the strength layer. It has 3 to 4 different layers, depending on which part of the abdomen we're talking. And it holds everything in, so things don't protrude out. It's a wall, so it prevents all your organs and your solid organs, your intestines to stay inside so they can't come out.
Okay. Now, do you always use mesh when you're doing the bars procedure?
Typically, the bars procedure is based on mesh.
Okay.
You have to use some sort of mesh. Now, there's different types of mesh that we use.
Right.
We use synthetic. We use biologic. Biologic means that it becomes part of your body. But yes, you have to use a mesh because you need some sort of material to create that internal corset.
Yes. So I talk to a lot of patients. Mesh can be one of those kind of touch words for them that they don't fully understand the purpose of it. And you just explained well. I mean, it is a support system.
Right.
What I find interesting about mesh is how the body kind of integrates itself. I'm talking in layman's terms now. Can you talk to us a little bit about that? Once the mesh is placed, over time, the body stimulates itself to kind of weave itself into that, if I'm making any sense.
Yeah. So that's a good point. So there are different types of mesh and different ways that they incorporate. So a synthetic mesh is a piece of plastic, just on a simplest level, and your tissues will incorporate through that mesh because those meshes have pores. And some of them are very small, microscopic, or just a quarter of a millimeter. And your tissue will kind of embed it themselves into that mesh. So
kind of grows into it.
So it becomes a scaffolding for that new ingrowth of the fascial layer and supports it. The biologic meshes work a little bit different. They kind of incorporate into the tissues that they're next to.
Okay.
So what they're touching. So if I put a mesh on a wall, and let's just say that mesh says, okay, I'm next to this wall, so I'll become just like the wall. So it makes the wall a little thicker.
Okay.
And that's how they work.
Okay. So it's a natural way of kind of building up the scaffolding, so to speak. Yeah. Is there much scar tissue that develops then after bars, internally? Because I know patients talk to me about scar adhesions, pain, stuff like that.
So you always get scar tissue when you do surgery because you're violating, for lack of a better word, a plane that you're not supposed to really be in.
Correct.
So the body says, okay, something's happened, and we got to rebuild everything. So that's the scar tissue. It's a normal process. Adhesions occur more with intra-abdominal surgery. So if you have a complex hernia that we're fixing, and then we go in and we have to put their intestines back in, scar tissue will form in there, and that can sometimes create adhesions, which can be problematic in the future, but it's a very low incidence.
Okay. So to kind of follow up on that then, is there any physical therapy that you recommend for patients after they have bars of any kind that helps with the recovery?
Believe it or not, most of our patients don't need physical therapy.
Okay.
We obviously will choose patients that are optimized for the surgery, so we know that they can handle the surgery and they have a speedy and good recovery. Obviously, if the person's a little older, don't have enough support staff at home, or could just benefit, from a little bit of therapy, we will send them to core strengthening type of physical therapy.
So what does being optimized for surgery look like?
Just good nutritional status.
Yeah.
Any comorbidities like high blood pressure, diabetes that's well controlled, and are able to kind of function and do their activities of daily living.
Yeah.
Those are kind of things that we look for.
Yeah. So you talked about too, like having support at home for recovery is important.
It is. The first couple of days after surgery, sometimes our operations that we do, the bars technique, we send the patients home the same day.
Wow.
We don't keep them overnight. So in those cases, for the first 24 to 48 hours, you want to have someone just with you. Help you with the bathroom, kitchen, that kind of stuff.
Sure. Yeah. Depends on the complexity of the bars that you're doing. Yeah. Well, this has been fascinating. So if you're listening and you're a patient and you haven't heard about bars, I'm speaking again to Dr. Tushar Patel at the ARSA Summit, and we'll have information at the end of this interview so that you can reach out to them for more information. And maybe I'll find out about a couple of those studies too, and maybe we can weave those into the show notes and stuff. Yeah. All right. Well, great chatting with you today. Thanks so much.
Thanks for having me.
Yeah, absolutely.